And we are now into our second session in the alternative approaches track, and you're in for a treat. I know, for one, that as a local mental health authority, behavioral health services, we have medication-assisted treatment in the form of opioid alternatives. We also have some help in our outpatient clinic, and so you're here to hear from a couple of subject matter experts that are in the field of medication-assisted treatment. And so we have Dr. Caro, C-A-R-O. Caro is for the non-beautiful language people like me. And then Dr. Rogers, and they will talk to us about the F.I.R.E. program, Igniting Lives in using through psychology. So thank you, and help me welcome the two ladies to this dais.
Well, good morning, everyone. I'm Dr. Caro, so let's just get started. For today, we want to just go over the overview of substance use trends locally and nationally. I won't spend too much time since the bulk of this presentation is MAT, and we want to make sure we get to that. Talk a little bit about the commonly misused substances, as well as the features of a substance use disorder, diagnosis, treatment, which includes MAT, and best practices. Before we get started, we got a little general taste of who's in the audience, but is there any mental health clinicians here? How many? Okay, law enforcement. Okay, judges, legal, anything I did not mention? Probation. Well, welcome, defense attorneys. Okay, so how long have we been in the field? 2 years and less? Anyone? 5 years or more? All right, we got some experienced folks in the audience. So before we get started, I kind of wanted to survey a little bit of some of these questions, right? So what is your understanding of MAT? We're professors, so we will stay quiet till we get an answer. Yes?
It's medication-assisted treatment, so for individuals, there's medications that are FDA approved specifically for substance use cravings and reduction. There's medication for opiates, there's medication for other classes like alcohol and things, and it's to reduce relapse.
Well, that's our presentation, so we hope you enjoyed. Thank you, yes. Anyone else? I mean, that was a pretty good summary. What are some misconceptions in terms of times? I'm just going to get to it. Yes, of MAT.
That is swapping of addictions, that we're giving them kind of like what they used to talk about when they were talking about something that says you're just swapping your substance use.
So kind of replacing one thing with another. Yeah. What else? What other misconceptions are there?
It's a cure.
It's a cure, yes. Well, have no fear. We will get to that at some point in the presentation. So I'm going to go through this pretty quickly. I just wanted to lay a foundation of, well, why are we here and why is MAT a thing, right? So 48.5 million Americans as of 2023 have met a criteria for substance use disorder. And so that's very important to talk about. Not only is it, okay, yes, this is something we need to pay attention to, but this is just in terms of who met criteria for substance use disorder. In terms of breaking down some of those statistics, we have information that there are some gender differences. If we're just talking about men or women, men have been found to use more than women, but doesn't mean that women don't develop dependence rapidly or at the same rate in terms of using substances or having a disorder. Actually, it's been found that women in recovery are more susceptible to cravings and relapse, and they get prescribed opioids or prescription medication in higher doses, also just more frequently. And these There's also trends in different communities of color, gender, and sexual minorities. So substance use significantly impacts our society. I think that's an understatement. And drug overdoses are one of the leading causes of injury death in adults. However, there is some good news in terms of the trends. 2023, 2024, and now provisional data for this year has shown a decrease in overdose deaths. However, it's still a problem to be paid attention to. And synthetic opioids and psychostimulants continue to be the leading causes of those ODs, disproportionately so, as you can tell. This is kind of just being repetitive and really honing in that point of opioid use and its ties to overdoses and overdose deaths in the United States as well as in Texas. Specifically in terms of Texas, there has been key findings. This is a 2025 study that has shown an increase in more than 75% of the state's drug overdose deaths in the past 5 years. And there has been a steady increase. And there's also been some coinciding data with COVID-19. We can do a whole presentation on the impacts of COVID with substance use. Maybe we'll be back and talk about that. But for right now, again, as is with nationwide, Texas has also seen overdose deaths caused by opioids. So taking this data, what does this all mean? So there's different consequences that we can see on a societal level, some of that economic. It's projected to have cost the U.S. $2.7 trillion in the year 2023, with broader estimates of $740 billion. This is not also healthcare expenses, employment, workplace productivity, crime-related costs, all kind of fall under this economic burden. In terms of health, overdose deaths, spread of infectious diseases, as well as effects on unborn children, to name a few, as well as instability across life domains, such as homelessness or housing instability, involvement with the child welfare system or child protective services, intimate partner violence, and this is just to name a few. So what are some commonly misused substances? We talked about opioids, psychostimulants, and that is methamphetamines, amphetamines such as Adderall. We have sedative or hypnotics. Here are your benzodiazepines, alcohol, tobacco, cannabis. And for my coffee drinkers in the room, alcohol is the second most used psychoactive drug aside from caffeine. As I'm standing here just swimming in a pool of caffeine. Tobacco use remains the leading cause of preventable disease in the United States. And also we have psychedelics, and this is shrooms, LSD, the like. So I'm not going to spend too much time on the effects of these substances, but it is important to note alcohol, trouble making decisions, solving problems, marijuana, maybe a slower judgment or reaction rate. And then we have some other common effects of some used substances such as MDMA, confusion, problems with cognitive functions like attention, memory, sleep. But I really wanted to hone in on opioids a little bit more due to MAT and its use in treating opioid use disorder. So on average, 217 people died a day from opioid overdose, and this is using the 2023 data. The number of opioid-involved deaths have increased substantially throughout the decades, and opioids itself are used in healthcare, right, for chronic pain, for after surgeries for severe pain, and if we trace back kind of how we got to this situation, prescription, right, and overprescribing opioid medication. It's driven from or mimic a natural substance in the opium poppy plant, and something that we would really like to highlight is the biological components of opioids. It works in the brain to produce a variety of effects, which includes pain relief. It also provides relaxation and feelings of happiness. And when we talk about opioids or overdose deaths involving opioids, this is not just illegal drugs, this is also prescription pills. And actually 75% of the people in this country who have become dependent on street opioids like heroin have indicated that they started off with prescription opioid drugs. So a little bit in terms of the withdrawal time course, I'm not going to spend too much time here, but this is again just to show the biological effects of using or stop using, right? And so if we think about the legal arena or clients we frequent that might be exemplifying some of this, could it be because of withdrawal? Could it be due to other explained medical conditions, but things to think about, how long it takes to really diminish symptoms from withdrawal and the danger of experiencing this withdrawal without supervision or medical assistance. A brief word on fentanyl, because it's most associated with recent overdoses. It's usually made in labs, and multiple issues are at play when we talk about fentanyl. So people may be under the impression that they're maybe consuming medication out in the street, that they're buying Xanax or cocaine, but fentanyl is becoming more prevalent in some of these. And I remember, I don't know if it was a few years ago, time's a blur, but where they were packaging as candy for youth, right? And this is all fentanyl. And so just the danger that is associated with fentanyl and being able to keep an eye on that. Now Dr. Rogers is going to take over for a few.
Excellent, thank you. Good morning, everyone. So as Dr. Caro outlined, substance use disorders, or substances in general, are problematic, specifically opioids. However, I want to spend a little bit of time on the difference between somebody who uses a substance versus somebody who actually qualifies for a substance use disorder. So the features of a substance use disorder, think about it as problematic. It's compulsive use with loss over control, over intake, and emergence of a negative emotional state upon stopping of the chronic use. And so just quickly highlighting some features. When we think about the physical versus the psychological, so physical is more of the body adapting to a drug, and then next slide is going to talk about the psychological. So the body adapting to the drug is that dependence on the drug. In the criteria of a substance use disorder, there is criteria A.P.P, and so A.P.P is the body needing, the craving of the substances, and that's more of that physical component, that biological. Also eliciting drug-specific physical or mental symptoms if use is abruptly stopped. Whereas psychological condition in which a drug produces a feeling of satisfaction. And so the bottom line, to conceptualize the two, the physical, the biological, the body's dependence on the drug versus psychological, more of the coping aspect of the drug. And so if it's physiologically dependent on the drug, that's where MAT really comes into play versus the psychological aspect of somebody saying that they need the drug for depression, for psychosis, etc. And so the bottom line, the etiology is defined as what causes this. So the etiology of substance use disorders, the desire to feel good, stop feeling bad, better performance, curiosity, or belongingness, and increased substance use to get some good feeling. brain and body need substance to feel better. And so I'm going to talk a little bit more about that third bullet point. So here's the neurobiology of addiction. The VTA is the central aspect for dopamine. It's the dopamine pathway. And so when we look at the dopamine pathway, this is where food, water, some of those physiological needs are met. And then it sends a signal, the neurons go to the nucleus accumbens that sends it to the prefrontal cortex. And so by looking at this aspect of the neurobiology of addiction, the drugs stimulate the reward system under the VTA, which, as I indicated, is normally stimulated by food and water and sex and other pleasurable areas. And then once the neurons activate from the VTA that contains the dopamine, which is released to the nucleus accumbens, and as I stated earlier, the prefrontal cortex. And so that's what they're looking for, is to get that reward. That's why some people who are addicted to substances will say, I'm chasing that first high, because it's literally what their brain is telling them. And so some people think that, oh, they're using it as an excuse. But no, if they're physiologically dependent upon the drug, then that is the biological aspect, versus if they're psychologically dependent upon the drug. Are y'all tracking me? Okay, excellent. And so when there is this biological predisposition. So biological predisposition, just like when we talk about trauma starting in the womb, substance use addiction can also start in the womb. And so if a parent has used substances, or even if a parent is under extreme stress or trauma, it affects the brain development. And when it affects the brain development, that it means it is affecting, going back to this slide, these areas of the brain, such as the VTA. And the child is yearning for that hit, if you will. And so looking at if they were exposed to any substances in utero, or if they've had any type of brain abnormalities as well. And also looking at different mental health problems. And so, for example, if somebody has schizophrenia, sometimes they like to use methamphetamines, or even cocaine or heroin, and even marijuana. Psychosocial stressors. I go to many attorney conferences. In the last 3 weeks, I was in Virginia, I was in LA, and I've been in Ohio. And let me tell y'all, at these conferences, your happy hour, and I'm not talking about the food. And so we have to be mindful of, just like I tell my clients, is it celebration or self-medication? And I encourage you to even pose that question to yourself. Is it celebration or self-medication? We can't celebrate every victory, every win with a sip. Because when that happens, we are activating our VTA, the dopamine, saying, oh, this is something positive, this is great. And it's connecting to that. And then when something negative happens, if we also take a sip, and next thing you know, we're taking a sip for everything. And so looking at what are some psychosocial environmental stressors that could be causing somebody to drink, if the home is an unhappy place, if the workplace is an unhappy place, even academic failure or just other failures in life. And early initiation of use, there's plenty of research, a plethora of research that talks about if a child starts using substances. Some research says 10, some research says 12, but either way, in late childhood, they're more prone and more likely to develop a substance use disorder, old school language called dependent. And just quickly, again, there are some people who use substances that they have problematic use, but it's not a pathological problem. So being able to differentiate between pathological pattern of behaviors related to substance use and just problematic use. And so the DSM outlines the different criteria. Looking at treatment of substance use disorders, there's many different types of treatment that one can engage in. And so even if somebody has a physiological dependence to a substance, recovery is possible. And so as we get into recovery, before Dr. Caro does a deep dive, I just want to say words matter. So for our mental health practitioners who are writing up the notes in the intake, making sure that we're using people-first language to make it least stigmatizing on the individual. So using non-stigmatizing language, person-first language, learn terms to avoid. Instead of saying an addict, a person who is addicted to a substance, those aspects matter, because if we say an addict, then we start to conceptualize the person as being just that. But if we say so-and-so abuses substances and they have a substance use problem, then we see that they're a person first and everything after. It's the same thing when we say a person who has schizophrenia versus a schizophrenic person. That is not all of who they are. So we want to make sure that we use person-first language and scientific language. All right. And so I am going to hand this off to Dr. Caro to talk about where do we begin, and then she's going to do her deep dive into MAT.
There's a pop quiz on the brain areas after this presentation, so I hope everyone was paying attention. But just a quick to emphasize some of this point. Research has been shown, if we talk about alternative to incarceration programs or drug diversion or any of those diversion alternative problem-solving courts, however you would like to name them, if an individual feels or perceives that the team, whether it be the judge, the community programming, case manager, et cetera, does believe that they are a person, that they can change, that is active in their participation and invested in their treatment, it increases their success in these diversion programs. So just would like to emphasize these points to keep this in mind. So where do we begin? I feel like I can slow down from the beginning half of the presentation since we were trying to get to this point. But prevention efforts are key, and I don't think this is groundbreaking, breaking news to anyone. And it begins with education, right? It's not just, as Dr. Rogers stated, we know that a lot of individuals who in adulthood use substances problematically have an early initiation use of substances that dates back to their adolescence. So we want to make sure individuals have the updated information, individuals being us as practitioners or who we are dealing with them on a daily basis on different aspects, that we are educated on the impacts of substances in adolescence, what that does for brain development, what that does for their social development, environmental development, et cetera, et cetera. And we also want to then be able to provide them with appropriate education on the most up-to-date information and treatment choices, right? When you give people better options, they make better choices. So a multidimensional approach to treatment is key. So in starting to think about intervention, for youth and adults, prevention is the best intervention. I don't think I made that up, but it sounds like I should coin it. But it is, right? Preventing substance use disorder is the best way to prevent overdose. And learning about effective prevention programs, when we were introduced about there being a clinic, either being linked to those, any specific treatments in the community, which I will go into a little bit, that can include harm reduction, right? And harm reduction may challenge some views of abstinence-only recovery or whatever have you, whatever your belief is, but we're trying to meet people where they're at. And using evidence-based treatment as well as recovery support. So talking about a little bit more on that varying approaches to substance use, which includes MAT, harm reduction, right? So harm reduction has come out of the belief of being able to protect the rights of individuals who use substances and be able to incorporate a spectrum of interventions and strategies to be able to meet them where they at, including safer use, managed use, addressing conditions of use with the use itself, And this could include syringe service programs, needle exchanges, naloxone to prevent drug overdoses. Sometimes, individuals are maybe not be ready to stop using. So we want to make sure we keep them alive and help them to be able to get to that point. Harm reduction may be a step in that direction. Inpatient, outpatient treatment services, this is structured setting, intensive treatment, whether it be groups throughout the day, individual therapy, case management, medication, et cetera, acute stabilization and withdrawal management, supervision, monitoring of detox, because as we saw, there is a biological component to these substances, specifically opioid use, right? So while maybe in choosing to use that substance at some point may have been part of that, it starts developing to now it's a physical dependence and we just maintain it to stay alive. In terms of medication for substance use disorders, the use of medication in combination with counseling and behavioral therapies promote this whole patient approach. I want to repeat that. It's medication along with behavioral therapy, behavioral intervention. So it's not just the medication itself, but it's a combination, right? This treatment to be able to address all the needs of a person. We have the medication that addresses physiological symptoms, withdrawal symptoms, and we also have the psychological component, the behavioral intervention, and maybe even adding case management. Medications used in the treatment of substance use disorder, as it was eloquently relayed earlier, are FDA approved. And they use pharmacotherapy that are clinically driven and tailored to meet the needs of the individual. There are quite a few of medications used in MAT, and that what is used is tailored to the needs. Oh, there we go. So medications are often used to treat substance use disorders, specifically opioids. However, we'll see it with nicotine use as well as alcohol use. And they operate to normalize brain chemistry. So it's going back to this physical, this biological component. They block the euphoric effects of alcohol, opioids. They relieve these cravings, these strong urges to use. They normalize the body functions, and they do so without utilizing the negative effects of substances. And so a combination of medication and behavioral therapy. If you take nothing out of this presentation and you just think, oh, what is one thing I remember is medication plus behavioral therapy is the essence and the core component of this treatment route. And so research, this is evidence-based, MAT is evidence-based, and research shows that it's the effective treatment for preventing overdose deaths. It decreases illicit opiate use, as well as other criminal activity, increases the ability to gain and maintain employment, improves birth outcomes, also lowering a person's risk of infectious diseases. Some of these may sound familiar. Methadone. Methadone is the most widely used form of MAT, and it works as an opioid agonist, so it activates receptors in the brain, changes how the brain responds to pain. It's highly regulated, although one is not blind to the fact that this is overused, can be used and sold on the street, but it is supposed to be highly regulated. And it provides a level of structure that is beneficial to many. It's only regulated, only available at methadone clinics and supervised clinics.
Why is it attractive on the street?
It provides some of the same effects as opioids, right? So it's supposed to work as an antagonist, so a lot of individuals want that effect. Do you have anything to add?
It also stays in the system longer, and it is a substance that is known as opposed to getting it off the street, thus the harm reduction, and it is generally the people who do well with the methadone are the ones who do want to stop, and so this is a way to avoid having the withdrawal symptoms and successfully move on with their life.
And it does get rid of that or address those physical symptoms like those cravings. As I said, you should be up here with me. We have another medication that's used, and I apologize if I cannot pronounce, but these medication names, they never are really easy to pronounce. But buprenorphine, yes. Belongs to a class of drugs called partial opioid agonists, and so substances that activate the brain's opioid receptors, but to a lesser degree than methadone. And when I was looking up the use of MAT with youth, there has been studies that prefer this over something like methadone. Does not say that methadone won't work, it just depends on the youth, but this is commonly used in MAT for youth. We also have naloxone and naltrexone. Naloxone, a lot of us may carry it, but it's used as being able to reverse opioid overdoses. Who here carries naloxone with them?
I'm in recovery. I've been for 34 years. Was on the Livingston County BWI drug court team for like 7 years, and I was a purist because I came out of the old school Alcoholics Anonymous. It's like I didn't agree with any of that treatment. But there are studies that show that some people, if they don't get the medication, they won't recover.
Right.
And that's what changed my mind about using the drugs in order to get someone to be able to get recovery.
Again, did you guys see these presentations before I put it? I'm here because yes, right? I think that's also a misconception, this short-term use, and that may be the case for some, but recovery is a spectrum, and there may be someone who may be on long-term MAT as well, but I'll get into it in a few.
Thank you for sharing your story. I don't think she heard me.
Oh, thank you for sharing your story. Okay, so this also is a nicotine replacement therapy. So there's the patch that kind of delivers a continuous dose of nicotine, the gum, a spray, a lozenge, and these are over the counter, but there's also prescription nicotine replacement therapies. You may see Chantix, but that was recalled in 2021 after it was determined that a carcinogen was present or above the acceptable intake. Also, an antidepressant, bupropion, is also assists. They're hard to pronounce. Oh, I'm making it more difficult than it needs to be. Also assists with withdrawal symptoms that come with nicotine. Ceasing nicotine use is a very difficult to work on in therapy. It's one of the most difficult things to work on, and it works as an anti-stress, and it's like the stress about the impending stress that really keeps this cycle of nicotine use. And this specific Zyban is an antidepressant, as I was saying, assists with withdrawal symptoms that go along with ceasing use, such as irritability, mood changes, anxiety, etc. Also, for alcohol use, these medications have been FDA approved for treating alcohol use, and they include Camprol, naltrexone, and some of them work with being able to block opioid receptors associated with the reward that you get from alcohol use, as well as being able to restore the balance of certain neurotransmitters that are associated with relaxing, with calm, with mood, etc. Antabuse could be one of the ones that is more readily heard of, and that works with trying to, if you have worked with someone who has used antabuse, it works alongside a liver enzyme so that it does not break down alcohol. So you may start feeling sick, really getting rid of that association of alcohol equals pleasure. It's alcohol equals I'm getting really sick, I'm going to throw up, among other things. Other pharmacotherapy and treatment includes common antidepressants. This is typically not considered MAT, but they're medications that are used in the treatment because a lot of ceasing use does come with different mood changes, different experiences, mental health related experiences, and so these can help with those. As well as antipsychotics, mood stabilizers. I'm not going to go too much into it. Okay. Misconceptions. We had one. Replaces addiction with another addiction, right? And this isn't, it's not true, right? We're not substituting one addiction for the other. MAT is a clinical treatment, just like you would say maybe cognitive behavioral therapy, right? This is a clinical treatment for substance use disorders. In terms of, and again, MAT with behavioral therapy is the comprehensive treatment, not just MAT on its own. 2, MAT, you're not really in recovery if you're using MAT. And as we said, recovery is a spectrum. There's not one size fits all. So you might need harm reduction. You may need medication, either short-term or long-term, to be able to address that physical cravings and avoid relapse. So it's imperative to keep things in mind because we know that our stigma may get in the way. It's only short-term, right? There is no universal timeline for MAT. Some individuals may benefit short-term, may benefit long-term. It's like people with chronic diseases, right? You may have to be on medication for the rest of your life. You may need to be on medication until maybe that condition, like prediabetes, may subside. MAT is only for severe cases. MAT can be helpful at any stage of opioid use or alcohol use or nicotine use. Early intervention, what did I say, was the best prevention, right? So it can prevent worsening of the condition, improve long-term outcomes. And MAT is not evidenced, it is. It has been shown to be able to improve outcomes, be able to sustain sobriety, and cease behavior such as legal involvement. I'm not going to spend too much on this. I'm going to get tired from hearing myself say it. Combination of MAT with outpatient or inpatient, wherever the structured treatment is being given, behavioral treatment leads to increased successful outcomes, whether it be cognitive therapy, where you are targeting maybe unhelpful thoughts, behaviors, emotions that all underlie substance use, multidimensional family therapy developed mostly for adolescents with substance use problems, working alongside their family that is their main support system to be able to improve overall family functioning and derive the best support for the youth, or motivational interviewing, which has become synonymous with substance use treatment, and being able to incentivize individuals to change, to work alongside individuals on the continuum, the stages of change, and being able to address that accordingly. NMI has been found to be very useful in substance use treatment, although in treatment in general, I would argue. All right, Dr. Rogers.
All right, so as we come to a close, looking at barriers to treatment, but before I go into barriers to treatment and reasons why people don't necessarily seek treatment, one thing I really want to highlight is what Dr. Caro had said as it relates to short-term versus long-term. Just like there are some people who may go to the doctor and the doctor say, I need to put you on high blood pressure medication. Then you change your diet, you change your lifestyle, and you come off of high blood pressure medication and you don't have to take it. There are other people who change their diet, change their lifestyle, but their blood pressure is still high and they have to stay on high blood pressure medication. It's the same thing with MAT. There are some people who will use it in the short term to help them be in recovery for decades, and there are other people who may need it over time because everybody's body is different. So if it's a physiological dependence, meaning your body is dependent on on the substance, that is where the MAT comes in for a longer period of time versus if it's more psychological and it's used in the short term. Does that make sense, everybody? Okay. Excellent. So some people may not seek treatment because of a lack of insight. They have never been told that they have a substance use disorder. It's sometimes, think about it from even a cultural standpoint. You may go to the family gathering, or there are even some cultures who say, oh, you can have a glass of wine, but for some people, a glass of wine a day turns into a bottle of wine a day, and they do not necessarily realize that it's actually problematic until they have to stop drinking, to use alcohol, for example, until they have to stop drinking because they're on a medication and they realize they're actually going through withdrawal symptoms, or they realize their attitude changes or their mood changes. And again, like I said, some people do not consider themselves to have a problem, and therefore they do not reach out for help. Also, policies and systems. There are some individuals who simply do not have the resources or the funding. There is stigma, misinformation being presented, and then access to treatment and auxiliary services within probation offices and within the community. And readiness to change, which Dr. Caro highlighted, motivational interviewing really does help with individuals who may not have a readiness to change. And so looking at overcoming barriers to treatment, policies and systems, advocacy and education, even in your particular roles, access to treatment and services, what can you do within the laws and policies that are in place within your state and within your particular county, and understanding that you have to pay out of pocket and how that for certain access to Narcan or even certain services. So what is in your purview that you can actually implement change? And then enhancing readiness for change. And so if you are an attorney or a mental health provider, it's really good, I would say the starting point is to understand, is it a physiological dependence or is it a psychological dependence? Because if it's a psychological dependence, then that's where we really want to emphasize the treatment and really want to emphasize what may be going on with that individual where they don't necessarily need MAT, or if they need MAT, it's more short term. So even when you're advocating or representing them to your best ability, or bringing on a mental health professional to be able to determine if it's more physiological or psychological. And then considerations and best practices. So medications are often an important part of treatment, especially when combined with behavioral therapies, as Dr. Caro has been emphasizing. And I know the slide had not on there, but as she stated, and as we've been stating, MAT is evidence-based treatment. And so treatment plans must be reviewed often and modified to fit the patient's changing needs. Treatment should address other possible mental health disorders, because a lot of people may not understand the connection that a person has a mental health disorder and they're using the substance instead of actual medication or treatment. And so therefore, if you're able to diagnose and pinpoint that the person has a mental health disorder, that will also help to formulate a more comprehensive treatment plan. And substance use during treatment may be monitored continuously. Some people say, like, okay, they're continuing to use substances, but having that insight and knowledge as to why somebody may be using substances and they're in treatment will give you a better understanding if MAT is appropriate, because maybe it is a physiological dependence and not just a psychological dependence. No single treatment is right for everyone. People need to have quick access to effective treatment. And as we highlighted, since recovery is a spectrum, then having support services, so aid in long-term recovery. This includes a range of social, educational, and legal and other services, so that multi-modality approach and having a team approach. And think of Maslow's hierarchy of needs. Some people want to target the diagnosis but they don't even have food, water, shelter. And so Maslow's hierarchy of needs tells us the basic needs need to be met before we can talk about belongingness, loving, and support. And so therefore, if I supervise individuals who are social workers and work with foster youth, and it's like, no, feed them before you try to talk about why they did X, Y, and Z, right? So meet the basic needs first, and then actually cater to what else may be going on. And in these last 8 seconds, implementing a comprehensive integrated treatment model, explore MAT options, make sure you constantly are educating yourself, reduce barriers to access, engage in protection of rights and autonomy, have a continuity of care, and engage in teamwork. Here are our references, and thank you so much for your time today.
Well, thank you so much, Dr. Rogers and Dr. Caro. It's so nice to have you in Texas. Very informative, and we thank you for your work, not only in educating us, but in helping people have better lives.